cells sperm. Then there is the interstitium that contains the Leydig cells. The Leydig cells are going to produce the androgens, so basically testosterone. So LH secretion is regulated primarily by the negative feedback, as normal concentrations of the gonadosteroids inhibit LH secretion. So we went over the axis and we talked about how it was going to work on either the ovary system or the testicle system. So now we're looking at that testicular system. Reiterate, it is a cholesterol steroid hormone, and then it does not need that cell receptor because it goes straight through because it is a steroid. So testosterone metabolism, very key. Testosterone is converted to 5-alpha hydrotestosterone. It's potent. That mediates many of the differentiating, growth promoting, and functional aspects of androgen action in males. So it's testosterone gets converted into 5-alpha. Estrogens are also present. They act in concert with those androgens. They inhibit the gonadotropin secretion, and that helps also with bone maturation in the adolescent boy. They are actually bound to, so remember how we said that there's a lot of them are highly plasma protein bound. Steroids are transported that way, and we do look at this when we're measuring testosterone to make sure that we have enough carrying agents to get from point A to point B. Obesity actually affects this very highly. There's an overall rate of estrogen synthesis in the extraglandular tissue that rises with increasing body weight and advancing age. When we talk about BPH and prostate cancer, they do think that estrogen has a big component into, or the lack of estrogen sets them up for BPH. So physiological actions, we talked about this a little bit earlier. Testosterone itself and its active androgenic and estrogen metabolites. Major functions of the androgens in males include regulating that HP system, initiating spermatogenesis, formation of that male phenotype during embryogenesis, promotion of sexual maturation at puberty, and then increasing that lean body mass and decreasing fat mass. Spermatogenesis, each spermatogonium that undergoes differentiation after puberty gives rise to 16 primary spermatocytes. Each of them enters meiosis and gives rise to 4 spermatids and 4 spermatozoa. It takes approximately 70 days for the spermatocyte stage. The transport of the sperm through the epididymis to the ejaculatory ducts requires about 14 days. They start in the testes and get transported, so it takes about 84 days for the sperm to be able to be ejaculated. Maturation of the sperm occurs during the passage through the epididymis, as they are evidence enhancement of motility. So we get those tails ready and get them basically armed to get into the uterine environment for the sperm. They have to fight their way to make a baby. So final maturation of the sperm may take place after ejaculation into the female urogenital tract, and there are certain enzymes that encompass that and allow for that to happen. So there is a picture of that process. So you have your testes, your epididymis, and then you can see it's linked to the seminiferous tubules. Here is a cut of the seminiferous tubules. So here is what's going on. So here we have the spermatid in the cytoplasm, sperm head. There's that spermatogonium. So basically we have that primordial germ cell, mitotic division, and then we get in here to that primary spermatocyte, which is here. Then we start with meiotic division 1. That is a secondary spermatocyte, meiotic division 3. So know that it goes through both because you have basically mitotic when it is still that primordial germ cell. Once we get into meiotic, we already have a spermatocyte. And then we get these spermatids to the mature sperm cell. And then there is the process of it. So you can see here are the Sertoli cells, which produce it. Here is your axis, hypothal, gonadotropin releasing hormone, anterior pituitary, FSH, LH. FSH is going to be on the Sertoli cells, seminiferous tubules, we get spermatozoa. LH to the Leydig cells, testosterone. Okay, phimosis or paraphimosis. Phimosis is the condition where the foreskin is too tight to be pulled back over the head of the glans. Physiologic adherence of the foreskin to the glans and then it's just too tight to get pulled back over there. What happens, about 10% of foreskins remain non-retractile for up to 3 years of age. This reduces as the child gets older. Paraphimosis, that is when the foreskin is left retracted for an extended period of time. So a medical provider retracts the foreskin of an uncircumcised male penis, any type of action to that area, and then neglects to return the foreskin back over the glans and allows that to happen. It's a vascular engorgement, edema of the distal glands, and it is a medical emergency in its acute form, because not, you'll lose the tip of the penis. Balanitis. You can kind of have etiologies here. So it's just basically an inflammation of the glans penis. Another one is called balanopastitis, and that's when it involves foreskin. That would be more in your uncircumcised. Okay. Different mechanisms. It's really kind of like a skin irritation, and you would have to find out what the cause is. So you would have, maybe infectious, fungal, allergic, or irritant, and you would have to treat accordingly. It is actually quite common. About 11% of males will come into primary care or urology and be seen for that. So Peyronie disease. This is also referred to as bent nail syndrome. It is a fibrotic condition of the tunica albuginea. So when we're talking about the tunica albuginea, that is that supportive tissue, as you can see here, gets extremely fibrous. We have structure with that type of tissue. It can be there could be penile deformity, a mass, pain, and there also can be erectile dysfunction with it. So exact etiology is unknown, but what they do believe is that there is an influence of genetics, trauma, and then tissue ischemia. And then that's what leads to this fibrous plaque, basically, and that is excessive collagen. You can have a local vasculitis-like condition that leads to ischemia, leading to that fibrosis and calcification. Urethritis is usually a sexually transmitted disease that presents with dysuria, urethral discharge, and pruritus. Gonococcal versus non-gonococcal, so we either label it one or the other. So basically it's either gonorrhea or it's something else. So if it's something else, it could still be more sexually transmitted. As you can see, chlamydia is still down there. But also number 2 really is a Mycoplasma genitalium. If this is left untreated, we can have lots of problems, and you could get a salpinitis, epididymitis, orchitis. So it would be almost like a PID situation for the male if it's left untreated. So it would go into the other sexual organs other than just being in your urethra. Okay, priapism, pathological condition that persists 4 hours penile erection in the absence of sexual excitation. So basically, to get an erection, we have blood flow that comes into the penis. We have very specialized epithelial tissue inside the penis, and we have basically lines the urethra. So what happens is that blood flow comes in, and then we have venous congestion because we stop the outflow of the blood. So we basically cut it off, so it's no longer allowed to come back out, and then that's what maintains the erection. Nitrous oxide has a lot to do with maintaining the vasculature, has a lot to do with arterial dilation, as well as then nitrous oxide has a big impact on the loss of the erection called detumescence. So detumescence, detumescence, which is basically the loss of erection. Norepinephrine also is your neurotransmitter that is going to be impacting the nitrous oxide and the ability of the penis to react. All right. So what happens here with priapism is we have some issue that does not allow for that venous congestion to actually open up and allow the blood flow to go back out of the penis. So we have ischemic low flow, or you could be anoxic, or there is a veno-occlusive issue. Sickle cell is a big one here. Non-ischemic is related to high flow and more congenital. This also may be related to trauma. Some medications may also predispose. Complications do include penile fibrosis and erectile dysfunction. Cryptocortism and ectopy. So cryptocortism is basically an undescended testes. It can be one or both. So remember where we had 5 to 6 week old embryo and we get the SRY, and if we have SRY, then we change our Mullerian. We lose Mullerian, we keep our Wolffian ducts. All right, and then by the time that we get to birth, the scrotum has descended. So basically what happens with this is there is an incomplete migration of that testes. Usually not a problem unless you're seeing some other indications of a phenotype with cryptocortism. So if you would see some issues with, let's say, a micropenis or hypospadias, then you're questioning whether there's a sexual development issue going on. All right, testicular torsion. So this is a urologic emergency, and it's caused by the twisting of the testicle on the spermatic cord, leading to constriction of the vascular supply and time-sensitive ischemia and necrosis of the testicular tissue. All right, and that's why it's a emergency, because you can lose fertility. So testicular torsion is very common in neonates and post-pubertal boys, more so than adults, but it can occur at any age. So what happens here is that there's an inadequate fixation of that lower pole of the testes to the tunica vaginalis. If it's insufficiently or broad base, the testes may then torse on that spermatic cord. All right, and that's what's happening here. It has the potential for profound ischemia after we get that torsion. There's reduced arterial inflow. There's venous outflow obstruction. So you have increased pressure in here. It cannot get out. So everything behind that would be a risk of hypoxia and ischemic damage. Intravaginal, extravaginally, or long mesocorium classification. Torsion should be diagnosed clinically, and if there's a high index of suspicion, you need to get them where they need to go. All right. The cresometeric reflex should be assessed, and that would be absent in patients with torsion. So we would have no cresometeric reflex. That's actually how you would also differentiate from acute epididymitis versus a testicular torsion, because they're both going to come in with scrotal pain, and that's going to be the number one. So scrotal. There's a general theory that if it's greater than 8 hours, damage is irreversible. Orchitis or epididymitis, inflammation of the epididymis causing pain and swelling, usually unilateral, develops over a course of few days. So sexually active men, age 35 and under, it is most common. Chlamydia or gonorrhea, so there's some STIs again. And then what it's saying here is anytime you have sexually transmitted disease, both partners should be treated. So anytime we're talking about infection, so you have a portal of entry, and then you have your urinary bladder in here. We have the testes down here. So we have a port of entry. It is a retrograde ascent of the urinary pathogens from the urethra to the bladder, and then via the ejaculatory ducts and vas deferens, that leads to colonization and inflammation of the epididymis. There is a non-bacterial, and that is usually related to, could be drug-induced or vasculitic if it's not related to bugs. So usually microorganisms, because of port of entry, it could be drug-induced or vasculitis. Amiodarone actually creates an acute epididymitis. In older men, it may be more related to enteric pathogens. This may be E. coli or Pseudomonas. So that's what those enteric pathogens may be. All right, so age younger than 35, it's really going to be STIs. If they're older than 35, you're looking at enteric pathogens. The other thing that you have to consider is if it's men who have sex with men, you're going more for enteric pathogens because of the source. Other things, bladder outlet obstruction, recent instrumentation of the urinary tract, or systemic illness also puts you at risk. So this is a young person cancer, so age 15 to 40, with the mean usually being about 20 to 34. All right, but your outliers are there. Most commonly presents as hard, painless nodule on one testy, noticed by the patient or at regular clinical exam. We have feel your boobies for women, so that you should also feel your testes for boys and men. One of the things that they'll test would be elevated serum tumor markers, and they are diagnostic and aid in monitoring treatment response after you are diagnosed with it. How do we figure out what's going on? We actually have to remove the testicle. So once the patient would find that hard, painless nodule, you would get an ultrasound, and then the ultrasound would give us features, and then that would lead to a radical orchiectomy. So basically, we will remove the testes, and then that's going to give us histological diagnosis. We never, ever, ever biopsy a testicular cancer. Never. And why is that? Because what will happen is you have that scrotal, you have the mass in there. So what will happen if we go in to biopsy that? We could seed the cancer outside of the area, and then it would metastasize a lot easier. All right, so we don't ever biopsy. And maybe a question on an exam. All right, so it is very curable, usually about 95% if it's caught early enough. A lot of them, unfortunately, are germ cell, and those are the more malignant and like to spread. And there's just kind of a look at it. So there is a really good survival rate, but again, we do not want to seed this. We do not want to biopsy it because it will spread easily. All right, prostate gland. All right, so here is a picture of the prostate gland. So there's a couple different areas that you have to be cognizant and aware of. So we have what's called the transitional zone. We have an anterior zone, peripheral zone, central zone, and ejaculatory duct. When we're talking about BPH, and the reason that you have a lot of signs and symptoms of urinary hesitancy, unable to empty the bladder completely, is because you can see where this transitional zone is. All right, so most BPH affects these areas. So that is why we have a lot of problems. Here's the bladder. We also have a sphincter up here that gets to hit a lot of spasm. So these are the areas that are impacted by BPH. And you see 20% of cancers do hit the transitional zone. But down here, it's the peripheral zone that is more related to the cancers. And that's why you can have cancers that grow quite significantly, and you're not going to get your signs and symptoms of urinary issues until later. Usually what happens is we have a pretty good cancer growing before we'll get your lower urinary tract symptoms. So if they have urinary tract symptoms, it's usually going to be more of a BPH. You do have some cancers that ride here, but only about 20% of them. So just keep that in mind when we're talking about prostate. So BPH is benign prostatic hyperplasia, and hyperplasia is the correct term, night hypertrophy. It is predominantly due to two components. There's a static component, which is really related to the increase of the tissue narrowing that urethral lumen, which I just talked about. And then there's also a dynamic component, which is related to the increase in prostatic smooth muscle tone, and that is by those alpha adrenergic receptors. So we have a lot of alpha adrenergic receptors in our prostate, and that's where actually our medications target. You will have both storage symptoms or voiding symptoms, or one or the other, and that's why your signs and symptoms will tell you which one is which. So storage symptom versus voiding symptoms. Increased frequency, urgency, nocturia, and incontinence, that is related to the bladder. All right. Voiding symptoms is actually getting the urine out. So weak stream, dribbling, dysuria, straining. We look at things like a urinalysis, PSA, just to make sure there is no prostate cancer. You can have an elevated PSA because you do have hyperplasia going on in here, but it usually has to be higher than a certain level before we get concerned with cancer. Prostatitis, so this is a painful inflammation of the prostate. It's usually accompanied by an infection. Follow the ascending pathway. You have those lower urinary tract symptoms, dysuria, frequency, perineal discomfort, and then you may have some variations of fevers, chills, and malaise. Most frequent urologic diagnosis, less than 50 years old, and this is enteric. This is an enteric pathogen, E. coli. Prostate cancer, so malignant tumor of the gland in the prostate. Older men between 2000 and 2004, the median age was 68 years old. All right. So just like breast cancer increases with age, so the longer you live, the more risk of cancer you have. Remember, it's cellular turnover. Remember all those mutations that we have. So the older we get, the higher risk of cancer you will get. It's based on the Gleason score, and that basically gives them a score, and the higher score for prognosis. And there again is that picture. Often clinically silent, we do need to screen for it, the PSA, as well as the digital rectal exam. And then you can see here that we do have age appropriation. So you're going to have normal serum PSA increases with age because of BPH. So it will be elevated in BPH. What we look at, though, is there's a cutoff. So once it's greater than 10, doesn't matter what age it is, we get very concerned that we have more of a cancer going on than just the hyperplastic changes or the hypertrophic changes that come with aging. There is something to be said about the prostate cancer diet. High in fat, animal fat, red meat, dairy products increase prostate cancer risk. Obesity, because this is a testosterone and estrogen related cancer. Also advanced and aggressive forms if they are overweight. Fat may increase androgens, and this increases oxidative stress. So pro-inflammatory means that we have more omega-6 over omega-3. That kind of is it's a kind of statement there. So pro-inflammatory is omega-6 is more than omega-3. There has to be a balancing act. So if you have the appropriate amount of omega-3, it balances out the omega-6. Corn oil, which is why we don't recommend it, is pro-inflammatory. There is that we talked about that charred foods and nitrates in the processed meats. Be very careful. What you need to focus on: vitamin E, D, selenium, cruciferous vegetables, tomatoes. Erectile dysfunction, inability to achieve or maintain an erection sufficient for sexual performances. There are multiple options once this happens. Hypogonadism is something that you should rule out first, and that is testing the axis. All right. So what is the testosterone level? There is your penile erection cascade. You need a psychogenic, reflexogenic, or nocturnal. Psychogenic is basically afferent sensory stimulation. That's at your T11, L2, and S2, S4. It triggers central dopaminergic erection from the preoptic area. So psychogenic is basically being stimulated by sight, sound, triggers your dopaminergic reaction. Reflexogenic is basically what we see even in men with spinal cord injury above the sacral level. And that is genital stimulation, and that is mediated by the spinal cord and autonomic nuclei. Nocturnal erections that occur during REM sleep is likely to do as the suppression of inhibitory sympathetic outflow by the pontine and amygdala, so a lot to do with your sleep. So what are the etiology? So impaired local regional blood flow, vasculature, vascular. We often tell our patients you need to get some things under control. Any chronic diseases, and especially if they're vascular in nature. So we really hit those two and tell them that they need to get their chronic diseases in order so that we can treat their ED. We still give them medication, but it's something that may not work because of the changes that happen in the male reproductive system are a lot of times related to age. You'll have issues with sexual drive, ejaculation and capacity, testicular changes, and hormonal changes. It's kind of when we're talking about sexual drive, you could relate to health status, ejaculation, and capacity. It may take longer to get an erection. A lot of medications are on board that impact that. Remember, we have a lot of things that work on the alpha adrenergic, and a lot of them do hit the male reproductive. Testicular changes, we lose size and weight due to atrophy. Sperm decreases. Hormonal changes, there may be, obviously, we lose some testosterone. That's normal. We lose that GnRH, increased GnRH, we lose testosterone.